dermatitis. Atopic dermatitis is one such topic which involves almost any system in dermatology. There is an interesting quoting saying that if you know secondary syphilis or if you know syphilis, you know the entire medicine. But if you know the atopic dermatitis, now you know the entire cutaneous medicine. So such a vast of clinical manifestations have been noticed, and it is always a challenge to treat this atopic dermatitis, which is going to cause a lot of emotional upsets in the family. And that itself says that the severity of the atopic dermatitis. If a child doesn't sleep in the family, nobody else can sleep. So that is the moral of this story. And apart from that, if you look at that face of that child, see the fatigability in the eyes. So that itself says that, so that child had sleepless nights. And of course, that will have the sleepless families too. So this atopic dermatitis is defined as chronic inflammatory eczematous dermatitis with acute exacerbation with genetic predisposition with or without increase in serum IgE levels. Each and every word is important here, and it is going to be self-explanatory to say what the disease is. And as far as the epidemiology is concerned, when we were students, it was said that 6 to 7% of the population had atopic dermatitis. But when I became a postgraduate student, and from the Institute of Child Health, I published a paper that it has touched 18 to 20%. But now it has touched 28.4% of all the registered patients in the OPDs. And slightly there is always a male predominance, and that is more seen in infants than children. And the mean age of onset is 4.2 in infants and 4.1 in childhood. And aggravation of this eczema is found to be there in the winters, that is about 62%. So just to have a clear-cut classification of the disease, it is known as intrinsic and extrinsic. Why to know this intrinsic and extrinsic varieties is that, see, this extrinsic variety is most common, whereas intrinsic is less common with 20% incidence. And this extrinsic has got an atopic march, and it also says that there is going to be increase in the interleukin levels, and also the IgE level is going to be positive. So if we have an history of atopic march or a family history or this type of hay fever or allergic wheeze or sneezing, so that gives an indication that we should do an IgE levels. Otherwise, it's not necessary, since it is going to be an invasive investigation in a child. Getting into the etiopathogenesis of atopic dermatitis, previously what was thought as an immune dysfunction, now considered as a barrier defect, and with secondary immune dysregulation. Apart from that, various etiologies has been put forward, so it becomes multifactorial. So as far as the genetics is concerned, this group associated studies says that it is a DEFB1 gene, NOD1, and SPINX5 mutation is going to occur to produce atopic dermatitis. So this atopic dermatitis genetics is not only confined to atopic dermatitis, it can have associated changes with some other diseases also. As I say, it could be very commonly associated with ichthyosis vulgaris, because this gene, SPINX5, is going to cause filaggrin mutation, and that is going to have an associated ichthyosis vulgaris also. Next comes the environment, that is the climate, urbanization, pollution, and tobacco, breastfeeding and delayed weaning, obesity and diet. All these can predispose to atopic dermatitis. And then comes the hygiene hypothesis, where the early childhood infection by unhygienic contact with older siblings, protection against the allergic disease, and the farm effects, like what they call it as the children playing in the mud, are exposed much to the Saccharomyces rhamnosus, which is going to give some protective effect for this atopic dermatitis in future. How it works is that we know very well that this atopic dermatitis is going to be a Th2 dominant response, and that is going to be reversed with this farm effects. As far as the pathophysiology is concerned, it's very, very complex, ladies and gentlemen. To make it simple, we know very well there is going to be a balance between Th1 and Th2. Once that is lost, you get this IL-4, IL-5 and IL-3 increase, causing an increase in IgE from plasma cells and decrease in interferon gamma, which is going to be Th1 response. And recently, Th17 response is also found to be increased, which causes the basophils, and immune lymphoid cells of group 2 have been shown to be dominant sources for IL-4, 5 and 13, once again constituting the cycle, and regulated by a family of epithelial cell-derived cytokines directly released from the damaged keratinocytes, inducing, or that includes the thymic stromal lymphopoietin, which is going to release IL-25 and IL-33. All put together, that produces the upregulation of inflammation, and that is going to be the problem in the pathophysiology. Next comes the epithelial barrier dysfunction. What we saw earlier was the immune dysregulation, and this is the epithelial barrier dysfunction or disturbance. Filaggrin mutation is going to occur, and that is going to alarm the early onset of AD, that is atopic dermatitis. Release of epithelial cell derived cytokines, as we have already seen, thymic stromal lymphoprotein, and ILCS2 is going to release IL-25, 35 and 2S. So all these are going to cause the epidermal barrier dysfunction, thereby increasing the transepidermal water loss. So what was thought as immune function, now it has become a barrier defect, and even the barrier defect is going to produce a secondary immune dysregulation, which is going to add on to the pathophysiology. As far as the clinical presentation is concerned, the major aspect is the pruritus. You can see the second photograph where it was brought to my clinic where extensive insect bite hypersensitivity was there, and the child was kept on scratching. Macular erythemas, papules, papular-vesicles excoriation, oozings and crusting could be there in very acute stage, and lichenification, that's nothing but hyperpigmentation, thickening, and increased skin markings can be seen in chronic form of the disease. And xerosis, one has to differentiate xerosis from ichthyosis. If it is going to be just dryness of the skin, you call it as xerosis. If it is associated with scaling, then you call it as ichthyosis. And any damaged surface can lead on to secondary infection. The first photograph, I think you can appreciate the xerosis. And these are all the various presentations which can be commonly seen. That is a fatigable eye with a malar rash, and secondary infection. You can even note the nostrils putting out the purulent discharge or the purulent secretions. That is once again going to add up for the severity of the disease, and the flexural involvement with erosions, and the napkin dermatitis, which is very severe. You can even see the snags of skin hanging from the surface. So each and every photograph here is going to say which agent has to be chosen, how long to be used, what is the strength, and what is the vehicle have to be used. And as far as this clinical types are concerned, atopic dermatitis is broadly divided into infantile, childhood, and adult phase. 2 months to 2 years is infantile, 2 years to 12 years is called childhood, and above 12 years is called adult phase. We are not going to deal with the adult phase right now. And this is going to be the infantile phase. As I said, it's from 2 months to 2 years. Here, mainly the extensor surfaces will be involved, where the child crawls and gets the barrier defects. And the headlight sign will be more prominent, where you get a dusky cyanosis or a dusky skin surrounding the eyes, which is supposed to be due to vascular ectasia. As far as the childhood phase is concerned, you get the atopic dirty neck and the flexural. Commonly, the flexures will be involved. And here, the localized forms of atopic dermatitis can also occur in the form of eyelid dermatitis, hand and foot eczema. Cheilitis could be in the form of lick eczemas, vulvo-vaginal dermatitis or perianal dermatitis, nipple dermatitis, fissuring, which could be retroauricular, infraauricular, and preauricular. And of that, if you see an intraauricular fissuring, that is going to be pathognomonic, and it is going to say that nearly 80 to 90% of the patients, what you are seeing is confined to atopic dermatitis. And these are some of the clinical manifestations which can be commonly present. The first picture shows the juvenile plantar dermatosis, which could be commonly dismissed as the shoe dermatitis. And the second picture, you can notice the dyshydrosis. That is, you can even appreciate the moistness of the palms, and one can commonly see in that picture like increased markings, especially in the thenar eminence. and infantile seborrheic dermatitis is the third picture. And what we see as a common disorder, pityriasis alba, that is white discoloration or hyperpigmented patch in the skin which occurs between 5 to 15 years of age group, could be a marker for, these are all the markers, supposed to be markers for atopic dermatitis. Now, how do we go for a severity assessment? Mild, moderate, severe. Even though there are a lot of severity indices scores, I'm not going to talk about this because I'm aware that I'm talking to pediatricians and not dermatologists. And if it is going to be mild, less than 10% of the body surface area is involved, you call it as mild. And more than 10% of the body surface area is involved, you call it as moderate. This is just a ready reckoner. And if it is going to be sleep disturbances there, whatever may be the percentage involved, directly it goes into the severe form of atopic dermatitis. This could be the associated factors like allergic rhinitis, dry skin, infantile seborrheic dermatitis, allergic contact dermatitis, drug sensitivity, alopecia areata. Even in alopecia areata, one can see the marginal areas involvement. That is called as euphiasis. If we see euphiasis in a child, that is going to be a strong marker for atopic dermatitis. Food allergies, pityriasis alba, and as I said, juvenile plantar dermatosis. And these are all the diagnostic criteria, what we call it as Hanifin and Rutschkin. And itching is a must, where the itching has to be ruled out with other causes. And there are other criteria, of which 3 should be positive. But if you see this famous criteria, IgE is not taken into account. These are all the latest guidelines given by American Academy of Dermatology, which is slightly modified from Hanifin and Rutschka, but here it takes into account the IgE levels. And recently it has been said that the severity of the atopic dermatitis is directly proportional to the IgE levels. So it's always worth doing IgE levels in our practice with the eosinophil counts. And these are supposed to be the complications. It could be psychosocial, growth delay, bacterial infection, viral infection, and others. Why? Because there is going to be an alteration in the cell-mediated immunity in this condition. So as a pediatrician, being a pediatrician myself, I'll be much worried to diagnose only atopic dermatitis, and it is interesting to see that there are a lot of differential diagnoses which could mimic atopic dermatitis, and here a list is given. I'm not going to get into the details of it. As pediatricians, I know very well you can get into the differentials. This is for the completion's sake. Honestly speaking, practical aspect in my practice, I don't do any investigations because it is going to be a much clinical diagnosis. Only I do absolute eosinophil count and IgE levels to see the severity of the disease. And now the treatment options are multi. And here, how to get into the treatment is $1 million question. It is not that the dermatologist has to make a diagnosis and send the patient to a dermatologist. A pediatrician can make a diagnosis and even treat the disease to some extent, because some of the conditions are very resistant to the treatment, which requires a better modality of treatment which can be given by a dermatologist. For example, phototherapy, which cannot be ventured in a pediatrician's diagnostic area. Now, the treatment strategy is going to be non-pharmacological and pharmacological, and this non-pharmacological approach is going to have bathing, which is supposed to be very minimal, that is not more than 5 minutes, and a good amount of emollients has to be used. Emollients are of 3 types: grade 1, class 1, class 2, class 3. Liquid paraffin is class 1, glycerin or the humectants class 2, and the filaggrin substituted or ceramide substituted emollients come under class 3. In atopic dermatitis, the class 3 emollients are supposed to be used. Then it is not, the next question from the mother or the patient will be how much to be used and how long to be used, how to be used. Immediately after the bath, the child should be pat dry and the emollient should be applied liberally. How liberally it can be used? For an infant, you can go up to 150 grams per month. For a child, you can go up to 300 300 grams per month. And in adults, you can go up to 300 to 600 grams. Why I say this? Because everything has got a limit. And as far as the avoidance of precipitating factors are concerned, environment, most dry and most chill weathers can precipitate. Food, especially the high selenium content containing foods like seafoods, cocoa or the dark chocolates, and the nuts of any variety can produce this atopic dermatitis. Clothing, especially woolen clothing, can induce, and infections, of course, mainly the Staph aureus colonization, can increase the precipitation point of the atopic dermatitis. As far as the pharmacological approach is concerned, it is the cornerstone of the treatment is going to be corticosteroids, which is going to be topical and systemic, calcineurin inhibitors, topical and systemic, again antibiotics, antihistamines and others. As far as very useful in atopic dermatitis, if you see a drug called dupilumab, which has completed the phase 3 trial and it is going to act against IL-4, is going to be a much promising treatment. In the conclusion, one should understand that this atopic dermatitis is a dose of steroids and come down as the disease improves, and rotation of drugs should be followed, long-term moisturizers, sound knowledge of the disease, and parental education is going to bring down the empathy of the patient. Thank you very much for this opportunity given to me.
Like and subscribe Eagle Media Works.